I'm Helen Coster. I'm a 2010 IRP Fellow, and I traveled to Bolivia as part of my fellowship. I went there primarily to focus on Chagas disease, which is a neglected tropical disease that's endemic to Latin America and is particularly relevant to Bolivia, where 70% of rural people are infected with the disease. 900,000 people in Bolivia are currently living in endemic areas. So the goal is, as people improve their housing conditions, they're going to be less vulnerable to this bug and therefore this disease. About 50,000 people die every year from the disease, but it's a really tricky disease for a number of different reasons. First of all, it's transmitted by a bug that lives in the walls of mud huts, so it's a disease of poverty, along with many other diseases in this family, like schistosomiasis and lymphoma and Kala-Azar. So people who are at risk of this disease live in adobe huts. So they're mostly in the most rural areas of Bolivia, and they suffer from a lot of extreme poverty. The bug bites people on their faces while they sleep, which is why it's known as the kissing bug. And it leaves a parasite in their body that over the course of around 30 years, enlarges their hearts and ultimately kills them through arrhythmias of the heart. I've long been interested in this family of neglected tropical diseases, and they're called that because they affect people in areas of poverty, and they're diseases of the developing world. And huge inroads are being made in a lot of these diseases, but Chagas is one that's been ignored, largely because it's really not a simple disease, and also because it doesn't have the kind of fundraising potential that a lot of the other drugs do. With malaria, for example, you can start a bed net campaign, and school groups throughout the U.S. can raise money for bed nets. But this is something that's much trickier. It's a development issue. So once people have better lifestyles and no longer live in mud huts, there's a huge issue resolved there. But for the people who do have the disease, the drugs don't really work, and there's still questions about whether the drugs are actually effective. So there's still a lot of debate within the scientific community about the best way to treat the disease, sort of what the diagnosis is after they've been treated. Right now, they're still dealing with two drugs that were developed back in the 60s and that have questionable efficacy. The million-dollar question right now is how to get Western drug companies to commit the kind of R&D funding for a disease that is never going to give them any kind of commercial windfall. So once people are infected with the disease and once they're diagnosed, they start a 2-month treatment in one of these drugs. And the drugs have really bad side effects, which is why people who are otherwise asymptomatic are often really reluctant to take the drugs. A bigger challenge than actually the side effects is getting people to come to the clinics for follow-up testing. You have to remember that in a lot of these rural areas, the hospitals or the closest thing to a clinic is an hour or two walk away. People are working as farmers. It's just not easy for them to get the treatment. And so rural public health just has all these challenges of logistics. How do you get the drugs to the people? How do you get them for the follow-up tests? And when people don't have symptoms, it's really hard to convince them that they have to make these huge efforts to get treated. Another sort of development issue is that they try to convince people to keep their livestock 50 meters or more away from their homes, which is something that's quite intuitive to us in the developed world, but for people for whom this is their great financial asset, there is some negotiating that comes into play when they're trying to convince people to keep these animals away from their homes. But increasingly, we're seeing cases of Chagas in the U.S., both in the blood supply and in animals, actually in Texas are having it, and also immigrants who moved to communities throughout the U.S. and contracted the disease when they were younger and are now, decades later, seeing the effects of the disease. And they're getting treated in emergency rooms in Los Angeles and Texas and Miami. So this disease that starts in these rural communities in Bolivia, in many cases, or increasingly is ending up in the developed world and is becoming a burden of our healthcare system. Bolivia is the poorest country in South America. It has this history of exploitation by other countries that have been taking out their natural resources. And right now, Bolivia is at a time where it's trying to assert itself on the world stage. But when it comes to things like coca, Bolivia is diverting millions of dollars of its much needed resources to fight narco trafficking in Bolivia. And from a public health side, it's hard not to wonder whether if that issue didn't exist, if those resources could be diverted to, for example, better hospitals, or if the government couldn't be doing more to work with other governments to negotiate deals on drugs, or giving drug companies more of a commercial incentive to develop new drugs. Ironically enough, I'm also working on a story about Iran and Bolivia, and Iran's biggest investment in Bolivia to date has been a hospital in El Alto, which is north of La Paz, the city north of La Paz. So even when it comes to other countries cozying up to Bolivia, they're going where Bolivians are really affected. So they're trying to garner this sort of support by going where there's great need. So when Bolivians ostensibly see a brand new spanking hospital where they can get gynecological care for $2 a visit, I think probably the intention of the Iranian government is to curry favor there among real people in Bolivia, as well as the Bolivian government.